Hey, welcome everybody. This is UroNurse. We meet every Saturday at 9 a.m. Central Time. Of course, I am doing a remote, as you may have noticed, different backdrop. This is not a pretend backdrop. Really am sitting poolside today. I'm over in Florida. If you hear a train whistle in the background, that's the Disney train. No, I'm not at Disney. I'm over visiting my grandkids who live very close to Disney. So we got a great show for you today. As usual, if you have any questions, just go ahead and put those through on the Q&A. We'll take general questions. If you have any stories that you want to share from a panelist, I'll put those through. But in the meantime, if you're watching us on YouTube, great. Be sure to hit that subscribe button, hit that like button. If your first time to see us here on UroNurse, be sure to check out our website at uronurse.com to learn more about us. And here's our great group of panelists that we have today for you. We have Laurie Atkinson, who's got my name on her because we had some issues this morning trying to get her onto the screen, but trust me, it's not me. And we have Andrea Strong visiting us. And I just heard about a snowstorm that's hitting you, huh?
Yep. I was going to start here shortly, expecting up to 10 inches. So,
I'm sitting in Florida wishing I was home to see the snow. Isn't that crazy? And Laurie, how much snow were you expecting in the Chicagoland area?
Well, they originally, I think it was like 3 to 5 today, but then they dropped it, I think, now to 2 to 3. So
Yeah.
you know how that rolls. We'll probably get a dusting.
Yeah, right. They always like to predict the worst, and then you get something a lot better. Just gonna find my Q&A box just to see if anything is here. Nope, we're good. Anybody have any stories they want to share before we get rolling? Today's presentation is going to be on bladder cancer, given by Laurie Atkinson. Be a great talk. Looking forward to it. Bladder cancer treatments. But again, anybody have any stories they want to share?
I have a story kind of pertaining, not totally pertaining to what I'm talking about today, but it was a patient of mine. It was years and years ago. It's not really a funny story. It's kind of a story that's going to stick with me for the rest of my life, though. I had a patient that I was doing BCG treatments on, and for a very long time. We got to know each other, and his wife, they'd come together. Well, I happened to see them leaving the cysto room. And he's like, yeah, everything looks good. I'm so happy. He gives me a hug. And I'm like, oh, that's fantastic. I'm so happy for you. Well, he had a cardiology appointment right afterwards, which was downstairs from where we were at. And what happened is, I went to lunch and I came back, and a little bit later, somebody goes, did you hear what happened to so-and-so? And I said, no, what? He had a cardiac event and died downstairs. Sad. And then a few weeks later, I actually called the wife to give my condolences, and one of their children answered, and she just passed away too.
Wow.
It's sad, but it's something that just will stick with me forever.
Yeah. It's one thing in our particular practices, we don't see a lot of people die. It's no. Unusual. And I have a similar story that I could share. Early on in my career, there was this patient, very similar BCG patient, coming in for his bladder cancer treatment. He always came to the office with his brother. And the brother always came with him, and so it was pretty common. So I called the patient. Patient gets up, his brother gets up, as he always did. They start walking towards the door to come in to, go get escorted to the room. And the brother goes, boom, down on the floor, massive MI. First patient I've had to do CPR on in the office. And they said that, he never made it. He was, probably up in his 80s. So, but even with immediate CPR, and of course we're, our office attached to the hospital, so they were able to get him to the hospital pretty quick. We called the paramedics, but as you say, it happens, and it's kind of scary because it happens and you don't really appreciate it, what to do and have people die in your office, right?
I have a just cautionary bit of information that pertains to bladder cancer. When you're administering BCG in the office, we always use bleach afterwards for your protection. But remember that ammonia mixed with bleach creates a toxic chemical. It's it's chloramines or chloramines are produced. And if you breathe those in, they can be dangerous. So be really careful when you're bleaching out patients' urine after BCG.
Right. The ammonia that's found in urine. I do see a comment here from Rebecca Strickland. I shared the Find Peter story from last week at work because we were due for a JACO walkthrough. The nurses thought it was hilarious. Then one of them said, "Oh, I have a story about penile implants, that something came up and she walked away and I don't know the story." Well, maybe you can get this story to us for next time. It sounds like it's an interesting story.
And for those of you who wonder where Peter is, I don't know where Peter ended up. The last time I saw Peter, we stuck it on the doctor's desk and it was gone. So it's going to show up somewhere.
Yeah. It's like the words Waldo, right? Yeah. Well, great. I don't see any other questions coming in here. So I think we're going to let Laurie switch over to full screen. Hopefully we had it working earlier. We're good.
Okay. So I'm going to do a talk about bladder cancer treatments, but I'm focusing, because it's such a short time, on just intravesicle therapy. So this is just going to be a brief overview. Obviously, we all know the causes of bladder cancer. Of course, number one being smoking is a big risk factor. Chemical exposures in the workplace, used to make plastics, paints, leathers, and rubber. We got genetics, of course. I'm going to try to pronounce it, cyclophosphamide, a cancer drug, and radiation to the pelvis. So here's another brief overview of symptoms of bladder cancer. As we all know, hematuria is number one. Usually it's painless, gross hematuria. But they could present with urinary frequency, dysuria, pain in the lower abdomen, and back pain. Don't see too much of that, though. So this is just a picture of stages of bladder cancer. The TA, of course, it's tumor on the bladder lining that does not enter the muscle. We've got carcinoma in situ, which it doesn't show on this picture, but it's a high-grade cancer. It looks like a reddish velvety patch. It's almost like these patches are red in the bladder, on the bladder lining. The T1 tumor goes through the bladder lining, but does not reach the muscle. As we all know, when it reaches the muscle, it's usually pretty bad. T2, the tumor grows into the muscle layer of the bladder. T3, tumor goes past the muscle layer into the tissue surrounding the bladder. And of course, the worst is T4. Tumor has spread to nearby structures such as the prostate in men and the vagina in women. So I'm just going to briefly, I'm not really going to concentrate on these, but I just want you to know for those low risk, the low grade TA, bladder tumors less than 3 centimeters. Usually it's just a surveillance cystoscopy. These people they're just watched. So it's often they'll do the cystoscopy at 3, 9, and every 12 months. No therapy, no intravesical therapy for this. The very high risk, of course, when there's large volume tumors, the refractory T1 post-induction, refractory carcinoma in situ. And these are the bad ones that usually require cystectomy, bladder preservation when indicated in the clinical trials. So we're going to focus on intermediate and high risk. So the intermediate risk, these are the high-grade TAs, less than 2 centimeters or multifocal recurrence. So they have these recurrences of a low-grade TA. Those are people that we would give intravesical therapy to. The chemotherapy bladder installations, usually the gemcitabine and mitomycin. These include usually 6 induction doses, then monthly. And a lot of it depends on doctor specific. All our doctors are pretty different in how long they want to go with therapy. So BCG for 12 months for those that recur after chemotherapy installations. And these people usually get a surveillance cystoscopy every 3 months for 2 years, every 6 months for 2 years, and then yearly. The high risk, these are these recurrent high-grade TA post-intravesical chemotherapy, so the gemcitabine, mitomycin, induction, high-grade T1, very large TA, greater than 3 centimeters, and the carcinoma in situ. These patients will likely get full strength BCG for 6-week induction, so once a week for 6 weeks, and then BCG maintenance for 3 years. Again, this varies from practice to practice. Maintenance is usually once a week for 3 weeks. And then sometimes we'll reduce doses for maintenance for 12 months. And that's usually because of the shortage too. And a lot of times people develop a lot of, irritative symptoms and they can't tolerate it. So if they're unable to tolerate BCG or there's no BCG available, we consider the gemcitabine docetaxel, which we'll talk about a little bit later. These people will also get surveillance cystoscopy every 3 months for 2 years, and then every 6 months for 2 years, and then annual. So let's talk about BCG. We all know BCG. So obviously it's an intravesicle immunotherapy. It boosts the ability of the immune system to fight the cancer. Usually full strength is given 50 milligrams, typo, 1 vial in 50 milliliters of 0.9 normal saline. Again, induction is once a week for 6 weeks. Maintenance is once a week for 3 weeks. And BCG is definitely it's still the gold standard for carcinoma in situ. So mitomycin, it's intravesical chemotherapy, kills bladder cancer cells. It's given a lot after a resection of a bladder tumor. And the idea behind that is when they resect a bladder tumor, a lot of those little floating cells are still in your bladder, and they want to kill those cells so it doesn't, stick to the wall of the bladder bed and grow another tumor. So we give 40 milligrams and 50 milliliters of 0.9 sodium chloride. It's usually a 1 to 2 hour dwell time. And then we do once a week for 6 weeks for the induction, and then monthly maintenance for about 2 years. Again, that can vary. The other installation that I want to talk about is gemcitabine. It's also an intravesical chemotherapy. Just like the mitomycin, it kills bladder cells. And it's also given after a TURBT. We give 2 grams and 60 milliliters of 0.9% sodium chloride. It's a 90-minute dwell time, and it's also just like the mitomycin. It's once a week for 6 weeks for the induction, and then monthly maintenance for 2 years. Now, I had this conversation with one of our doctors yesterday and said, I see some of our physicians giving mitomycin, a lot after TURBT, but then now I'm seeing all this gemcitabine. So what's the difference? And so what we had discussed is that apparently gemcitabine is much cheaper, and so I looked it up, and mitomycin actually is hundreds of dollars as opposed to the gemcitabine, which is literally like $30. It's a lot cheaper. And they say that studies show that there's really no difference in outcome. All right, so gemcitabine docetaxel. This is something new in our office. We just started giving this probably a few months ago. And this is basically when BCG is unresponsive. So basically in our office, we are able to do these in our office. The downside with these, and they're both chemotherapy agents, the patients have to stay in the office. And the reason being is because after we place the catheter and we put the gemcitabine in, we put a Foley catheter in because that has to stay in the bladder for 90 minutes. Once the 90 minutes is up, we drain the bladder. And then you can see on the bottom here that this is our little docetaxel bag. Now we're in the process of seeing if do we really need to instill it with a bag or can we instill it with one of the syringes? Still yet to be determined, but I don't see what the difference is. We give 1 to 2 grams of the gemcitabine, and of course it's in 60 milliliters of normal saline, and it's a 90-minute, of course, dwell. Then we drain it. We put 38 milligrams of docetaxel and 50 milligrams of normal saline, and it's instilled after the gemcitabine is drained. The Foley is then removed. Now, after the docetaxel is instilled, the patient can go home. So we leave it. We take the catheter out, and that's a 2-hour dwell time after that. So patient instructions prior installation. I can't stress how much you need to educate your patients before they get these installations. In our practice, what we do is we always have a nurse go in and explain everything, because we're the ones that are actually giving it. We want to make sure that they have the expectations of what's going to happen when they get there, how long they're going to be there, what we're doing. So we always, especially with the gemcitabine docetaxel, they're there for about 2 or 2.5 hours. So we want to instruct the patient that they come in time for the visit, because we have limited rooms just like everybody else, and they take up obviously a lot of space and a lot of time. We ask that they don't drink fluids for 4 hours prior to receiving the treatment, and that's because we obviously we want them to be able to hold the treatment. And we just want to make sure that it doesn't get so diluted that it's got full potency. We have our patients because we do this in the office, we have the patients arrive and we do a urine test. We want to make sure that they don't have any sign of infection before we do it. We also want to visualize it, because if there's visible blood in the urine, we won't do the treatment as well. So obviously the treatments will be held if the patient has experienced visible blood in the urine or any urinary tract infection symptoms. So the instructions during installation of BCG, the mitomycin, and the gemcitabine, the medication will be instilled in the bladder through a straight catheter. The catheter will be removed once the installation is complete. The installation should be retained in the bladder for 1 to 2 hours to obtain the best results. Now, of course, with BCG, we instruct them for the 2 hours. Mitomycin, we do 1 to 2 hours, and gemcitabine is 90 minutes. We don't want them to hold the installation for more than 2 hours. People think the longer they have it in the bladder, it's better, but it's not. It's going to cause more irritative symptoms. It's not good to hold more than 2 hours. So we make sure that they know that, holding it for 2 hours could make your symptoms worse. Now, rotating, we used to tell people to rotate every 15 minutes, side to side, back to front, but it's a little controversial. We don't really tell people to do that anymore. We give them the option if they want to. The whole thought process behind that is by flipping around like a fish, you can get that, the installation all over the bladder. But studies have shown that it may not even work. So I give them the option to do it, because that's what we did for years and years and years. So preparation, back in the day, because I've been doing this for 24 years, back in the day, I'm surprised we even had gloves on. We would do this open, we would have needles and everything, I was pregnant through all my kids doing these treatments and everything. Now, obviously pregnant women, breastfeeding women shouldn't be doing them. Now, they even want it, obviously it's now usually as a closed system or under a hood. So that's what we don't do it in the office, because we are lucky enough to have a pharmacy on site or in a hospital. So our pharmacy, we're able to release a therapy plan to them. So when the patient comes in, does the urine, we're okay with giving it. We send a therapy plan to the pharmacy, who will mix it for us. We go and pick it up and we bring it to the office to instill. But again, BCG can certainly be done under a closed system. Mitomycin, gemcitabine, docetaxel, those should be done under a hood because of the chemo agents. So what are you going to need for this installation? So proper PPE, like I said, I never used any of this except a regular pair of gloves back in the day. So it is suggested that you use a chemo gown, you have chemo gloves, a mask, and protective eyewear. And here's just a little picture of, how our little setup is. We have this catheter tray. It includes the cleaning swabs, drapes, tray, and catheter. We always do extra chucks because, some of these treatments they don't always go as planned. Sometimes with gemcitabine or any of the treatments, sometimes they can bladder spasm or what have you, and you make a mess and you just want to avoid it getting all over them and ourselves. Of course, the lubrication, we do use lidocaine jelly, the Glido. We don't use it on women necessarily. We usually use it just on men. And then, of course, the installation, and this happens to be mitomycin up here. You always want to tell the patient, especially with mitomycin, that it is purple, so you're going to pee out a really weird color. Post-installation instructions, we tell patients sit down to avoid splashing. We also tell them, if you have a separate toilet in your house, try to use that, for the time being, just so that nobody else is exposed to anything. We have them urinate and empty their bladder fully. So obviously we want to start flushing this stuff out. After urinating, and I probably should put in there that we do, I don't know about Andrea, but we do let patients go home after BCG, gemcitabine, and the mitomycin. So after we instill it, they do go home. After urinating, we tell them to pour the 2 clips of bleach into the toilet, let the urine and the bleach stay in the toilet for 15 to 20 minutes before flushing. We want to kill it before it goes down into the sewer system. Close the lid of the toilet before flushing so it's not splashing all over the place. We have them repeat this for the first 6 hours after urinating. By then, it's been pretty much flushed out by then or dead. So we have them wash their hands and genital area very thoroughly. I've heard and I haven't experienced this, but with gemcitabine, I heard when it gets on your skin, it can be irritating, which I haven't experienced with any of my patients, but it can happen. Obviously, now that they're peeing it out, we want to flush it out. So we tell them to drink a lot of water after they urinate for the first time, to now flush out the bladder and dilute it and get it all out. We tell them to avoid sex for 48 hours after each treatment. It's wise to use condoms during and 6 weeks after the treatment. Whether people really do that or not, I don't know, but that's what we recommend. So symptoms after the installation, again, it's really important to tell people before you even start the treatments, when we're talking to the patient and giving them the instructions, we want to make sure that they know the expectations of what they may have afterwards. And a lot of times it's the burning with urination, frequency of urination, urgency of urination, and blood in the urine. Now, these can last usually a day or two. I try to tell patients, and just with experience, that a lot of times people don't have any symptoms after these treatments. Some are miserable right off the bat. We don't know what's going to happen to them. I know just from experience that it seems like the further you go along in treatments, those symptoms can get worse. And I see that a lot after induction of the once a week for 6 weeks. After the induction, and you have that little break, and then you go back and they're like, oh my gosh, did you change the dose? Like, my symptoms are so bad now. And I think it's just your body saying, hey, you gave me a break and now you're just basically punching me again with this, and the bladder doesn't like it. We instruct them to call the office if they have symptoms that persist after 48 hours, because we get concerned, of course, anytime with any kind of installation that they can get a UTI. We tell them if they have a fever greater than 101 degrees, they need to let us know. There is such a thing called BCG sepsis, which obviously gets into the bloodstream, which thankfully I've never seen, but people can get really sick from that. They can have increased fatigue, especially with the gemcitabine and the mitomycin. They can have fatigue from that, but if they get worse, we need to know. Flu-like symptoms, and then of course blood in the urine with clots. Obviously, we want to make sure they're peeing okay. So BCG shortage. Obviously, we're all going through that. And luckily, I haven't had an issue where we're at. We do have a particular allocation through our pharmacy and our office that we receive this. We have not come into a bind yet. But we do have patients that are finding out who has BCG and who does not. And so they find out we have BCG, or another office says, oh, we know that they have BCG. Now they're trying to give us their patients. So we've kind of had to put a halt on that. At first it was, if we had the supply, we could, but we have to make sure that we have enough for our patients as well. So I know that some of the offices will do half dose, the 25 milligrams of BCG, because obviously we want to, half dose is better than nothing. So if you split it, at least 2 people can get it rather than 1. We do want to schedule these people at the same time to avoid any waste. BCG is only good for a short period of time after mixing. So you want to make sure you can give those both at the same time or near the same time. And then, alternative gemcitabine and mitomycin, of course. And some doctors will use the gemcitabine docetaxel as well. And these are 2 of my favorite RNs, and they were gracious enough to take this picture of them. So does any?
All right. Now I can see us. We did get a comment from Paula Wagner. And let's see here. Sorry about that. My screen just went blank.
You're frozen now. Oh, there you go.
All right. So what happened is actually I have this thing that causes it to keep people from interrupting me with other calls. And my daughter's on the override. She was trying to call me, so it overrode and put her through. I think we're back, aren't we? Am I unfrozen? Mm-hmm. Okay, yeah. So Paula Wagner put through his question. Exposure, or not a comment, I should say, exposure to Agent Orange is a risk factor for bladder cancer. So I think that's one that we didn't necessarily comment on, but it is definitely another one of these risks. And we see quite a few of the guys that were post-Vietnam that have had that exposure risk. Right now I'm starting to
is that your granddaughter? I could see her in the window. There's a reflection.
It's supposed to be kind of like almost a reflection where you don't see anybody coming through it, but they're trying to keep them quiet. Trying to find a quiet spot in the house was nearly impossible.
Thank you, Laurie, for that. That was a great presentation. I wanted to elaborate a little bit on, you mentioned that people who are trying to conceive or who are pregnant need to, make special considerations. So I was able to find, the Oncology Nursing Society, ONS, my previous employer actually made us get a special certification through them when we were administering any chemotherapy agents or BCG, just so that we are able to understand how to protect ourselves. So I just want to read off from their hazardous drugs toolkit a little bit about pregnancy and breastfeeding, or if you're trying to conceive a child. So handling hazardous agents may result in reproductive risk, including structural defects in a fetus, adverse reproductive outcomes, including fetal loss, miscarriage, and spontaneous abortions, infertility and preterm births, as well as learning disability in offspring of nurses exposed during pregnancy. Although consistent and thorough use of primary engineering controls and personal protective equipment when handling hazardous drugs minimizes risk of occupational exposure, it does not eliminate it. And then they came up with a list of things that you should consider if you're pregnant, breastfeeding, or trying to conceive. And this applies to males and females when trying to conceive. It says that employers have a responsibility to ensure workers understand the risk of exposure to these hazardous agents. All staff involved in the handling and administration should be familiar with and adhere to local and national policies. Each healthcare setting should identify available options for alternative duty and educate staff on these options. I spent some time in the float pool in the cancer center, and there were a lot of young nurses who were trying to conceive or were pregnant. And so they were able to offer them other positions during that pregnancy and breastfeeding period, such as telephone triage or administrative work. Okay, it's the responsibility of employees, male and female, to inform the employer if they have medical reasons to avoid exposure. Upon notification that a staff member has a medical reason to avoid exposure, employers should give those staff the option of alternative duties. We already discussed that. And then if you are trying to conceive or you're pregnant, you should collaborate with your primary care doctor or obstetrician in the decision-making process. So
Is that what happened to my 5 kids? I just thought they were kids, but apparently maybe BCG got to me. I don't know.
I think it's a good point, though, because a lot of institutions may not have regulations set up or have provisions for employees that are pregnant or breastfeeding, etc. I know our office, we didn't allow anybody who was pregnant to administer any BCG, and we didn't give a lot of chemotherapy in the office, but that would go along with that.
I was just curious to somebody who's out there how their office does it. I know that a lot of installations are done through like an infusion center, through a cancer center. I'm curious on other offices on whether they're giving chemo agents and BCG or just one or none.
Yeah, I don't see anything coming through. I do have a comment, Susie Swain, or maybe it was a question here. If the patient doesn't have to turn every 15 minutes during treatment, is it okay that they sit down and not have to lay down?
I let them sit up. A lot of the people, unfortunately, especially the ones that have to stay in the office and they have to drive home. So yeah, I tell them they can sit up for sure.
Yeah. I think if they're not doing all the crazy flipping around and stuff like, as you said, as a fish, that being mobile is going to help to mix the chemical around. So moving around, doing stuff is important.
Yeah, people were concerned way back in the day about, if I have to drive home and I'm 45 minutes away, and I'm like, well, just consider setting up one of your positions, then go home and move around.
Yeah. That article you'd read earlier about the mixing chlorine or the bleach with the pneumonia, which obviously urine has ammonia in it. I think is a bigger concern if you're doing it like in the office. Typically, patients void into something, then you add to that, so you've got straight urine that you're adding bleach to. Where we tell patients to put bleach in their toilet. Now it's pretty dilute when you urinate into probably a minimum of a gallon worth of water that's sitting in the toilet. Mm-hmm. So that I don't think that's ever been a concern of patients. But I will tell you that personally, I had a patient who had not closed the toilet lid and overdid it with the bleach, and they had a lot of chlorine exposure. Chlorine is a bladder irritant all by itself from bleach. So make sure you warn patients, be careful when they're using agents like bleach. The other thing I had is kind of a scary story off of BCG. Was a patient was sterilizing their leg bag for some reason. I don't know why they were doing it. I never recommended it, but they were putting bleach through it to get it real nice and clean, straight bleach. And bleach, of course, got on the plastic bag on their leg, caused a really bad irritated burn from bleach. So patients,
I've seen that before too.
Yeah, I think it's important that part of our teaching to include warning patients to be careful with that stuff.
Yeah. Also, I've had some patients in the past who needed to perform intermittent catheterization. They would go home to do their catheterization 1 to 2 hours after installation. And we gave them like a little mini yellow bucket to put that catheter in. And then they would bring it back and we would give it to the cancer center so that we make sure that we're not exposing our environment or some of the workers who, to any chemotherapy agents.
Yeah, good point. I do have a comment here from Neil Smith. It is common for patients to receive one treatment of gemcitabine or mitomycin. Oh, I'm sorry, it's a question. Is it common for patients to receive one treatment of gemcitabine or mitomycin immediately post TURBT, then proceed to BCG treatments in the outpatient setting? So I guess the combination.
I think it's pretty common now. I think ours pretty much always do that after TURBT. And I guess it's depending on the results of the biopsy. They gear towards the BCG or do they do an induction of gemcitabine again? It's really, I think, up to that pathology result.
Yeah. I'd read an article that stated that the post-mitomycin was almost as effective as the 6 treatments of BCG. And especially during the shortage, that was one of the go-to for a lot of our physicians, was just trying that first and then seeing on follow-up how they did. Now, did any of you get a chance to read the article about this FDA approval of a first gene therapy for high-risk non-muscle invasive bladder cancer? It's come out recently. So something finally that's going to be out there besides BCG. I will include something on the website about it. It's called, oh boy, Adsisteldrin. For basically, it's a gene therapy for patients that are they're BCG refractive. So it's another therapy out there that's we can look at and consider. Maybe a future UroNurse program, get somebody from the company to talk on that product, right?
Sure.
I picked the outdoors because I thought it'd be nice and quiet. I hear dog barking, train whistles.
We hear the dog.
Hopefully not too much of this is spilling over. What actually caused the system to go down is I was putting my headset on so that I would block all that out. Just the whole program shut down when I tried to, all the audio went off. So that's why it's off. Anybody has any questions from the audience, please feel free to put those into the Q&A. We're glad to discuss more.
Yeah, I wanted to throw in there too is, we talked about, the nurse going in to give the instructions, which is important, but it's also important to try to have consistency in who's doing the treatment. So if I start a patient, I try to do their entire, I'll do the instructions for them. So they already start that, trust with you. And then I will make an attempt to make sure that I do all their treatments. Of course, unforeseen things come up, but yeah, I think that the consistency really makes them trust you, and it just goes a lot easier down the line, and they have that go-to person. And you do develop a relationship with these patients too, which is pretty neat to see over, the years. So.
Yeah, I agree with that. I think continuity of care is really important, and it's really nice to build a relationship with those patients over time. I don't administer these treatments anymore, but I do miss that, every week you get to chat and really build a great relationship.
I think you also are better at evaluating a patient when you see them every week. There's that, like you say, you have that rapport, they feel comfortable talking to you about it. You kind of say, well, how's things going? And speaking of which, when do you hold BCG? Do you have any thoughts on that,
Okay.
Laurie?
Yeah, so we'll hold BCG, of course, if we think they have a UTI, blatant. I mean, you're going to get abnormal urine dips. They're going to show trace lukes and small blood. But if they have positive nitrates, that's a no, and they're not an azo or pyridium, that's a no-go. If we visibly see blood, we don't do it. Sometimes if we put a catheter in, and it's a difficult catheterization, and when you're putting it in, you see blood come out a little bit, and we will actually not do that treatment for that reason. So what if the patient's asymptomatic and their urine's a little bit off? Yeah, we'll still give it. We have a patient currently that he did fine for his first treatment. He did develop a UTI, and it's been this UTI that is not going away. And so, we were talking to the doctor yesterday who had put the patient on Cipro. In this particular case, had to put him on Cipro for 7 days. We had him come back in, and he still looked infected. And it's kind of been like that, for a pretty long time now. So this time he's on 3 weeks of Cipro, and we had to ask the doctor, should we do the treatment while he's on the antibiotic? But the problem with antibiotics is they decrease the efficacy of the BCG, mitomycin, gemcitabine. So, is it better to wait until we get a negative culture and then restart it, or do we do it while they're on it? Our doctor chose to wait, and let's get him clear first, and then we can resume it.
Mm-hmm. We used to hold treatments as well if they had the flu or any other infection, anything like that.
I think that's a real good point, that you want to make sure the patient's health is number one priority. Another thing I thought I'd mention is a lot of offices have this, routine of giving an antibiotic after procedures. So that's one of the procedures you do not want to give somebody an antibiotic, because a Cipro after BCG is a useless BCG treatment.
Yeah, we don't even actually give antibiotics anymore after like cystos or anything like that. We used to have, a jar of Cipro, a jar of Bactrim in the office, and we'd give them one afterwards. We're not even doing that anymore. We only give antibiotics. We have, injectable antibiotics in the office for those who may be, diabetic, prone to UTI. But it's usually just a shot of ceftriaxone or even gentamicin afterwards or before, depending.
And the guidelines really don't, say that you should be treating patients for routine procedures.
Right.
Prophylaxis is not recommended. I'd be interested if anybody out in the audience has any opinions about that. You can put it on the Q&A as far as whether your office is using prophylactic antibiotics after cystos, catheterizations, etc., just to see what people are doing out there. But definitely not to be done. And you were talking about urinalysis too. When commonly after BCG, you're going to see an increase in leukocytes. You're going to see that white cells. That's what you want. That's the body's building up its immune response. So that's a good thing. But of course, holding it for obvious nitrite positive. And we always, I don't know if you do a microscopy in your office, but we always do. So I always look and see if there's actual bacteria too.
We don't do microscopy in the office.
Yeah.
No.
And the dying art of looking under the microscope. I was raised that way from the start. I just never could, go by strictly what the strip says.
Yeah,
Although
there's probably not a lot of offices that do, the spinning and the making the slides. I remember those days too, but I don't think too many offices do that anymore.
And then Paula Wagner just said here, no patient biopsy. No pre-op antibiotics for procedures unless it's trust biopsy, which I absolutely. There's no way you can prep a rectum and have it be sterile. So you do need to cover for the pathogens.
Yeah. Now, I think the literature says there's a less than 1% chance of disseminated BCG infection. However, I did see it happen twice in my lifetime as a nurse here. And it's quite serious. Those patients had to spend a lot of time in the ICU. So just really keep an eye out for that. I had a patient, wasn't my patient, but I remember there was a patient who needed a orchiectomy. He was receiving BCG, but he also had incomplete emptying. And we think that may have resulted in an infection and an orchiectomy. So make sure that they're a patient who's emptying completely. If they're not, they may want to start them on Flomax or intermittent catheterization, or maybe catheterize them in the clinic before sending them home to make sure that all of the agent is out of their bladder.
Yeah, that's a good point. Yeah, we have a fair amount of patients also that have a hard time holding it. Whether it's overactive bladder or what have you, and even though it's a small amount, that could just produce them to feel like they have to go right away. And so there are a fair amount of people that we will actually keep in the office, even for the gemcitabine BCG or the mitomycin, and we'll actually place a Foley catheter and plug it and see if we can get them to hold it a little bit more. Now, Sometimes that doesn't work. Sometimes they spasm and it, leaks all around the catheter or whatever. But for the most part, it does help. Instead of them holding it, not being able to hold it and have to pee at 15 minutes, we may be able to get an hour out of it, which is better than nothing. So.
Yeah, we've tried the same in the past. And I've also seen with that catheterization, giving them an immediate release ditropan before the procedure to try to help.
And I have a trick that I always use that worked really well is, the BCG kit has the tubing, the bag, it's all a sealed system. So if a patient had bladder spasms, I'd have them stay in the office, laying on the table with that system left open, so not blocking it off. And every time they would get a spasm, it would just go up the tube.
Go up into the back. Yeah.
And then as soon as the spasm went away, it came right down the tube again. And they got, most of the time you could get patients to get their entire treatment for the length of time that you were looking for. Sometimes you would get some leakage, so I'd always pad around it just in case. But I was amazed at how well that technique worked.
Interesting. And now I don't think, if I may be mistaken, but I know they have the tubing for the BCG. I'm not so sure they do tubing for BCG anymore.
I know they don't package it anymore. You have to buy it separate. It used to be a kit.
So you can still get it, but it's separate. Okay. Yeah, there is another closed system with it. It requires a lot of devices. And the problem with that is these devices that you have to, the closed system, they're not cheap. They're a little expensive. So
I guess I'm not familiar with what this system is. Can you explain it?
So the closed system is how it typically came. The way the BCG used to come, and I know it's not anymore, is it had the bottle of BCG, you would reconstitute it and it had the volume of fluid that diluted it. And then it had a drip chamber, a catheter tip end on a piece of tubing, and you would go ahead and just hold it and let it gravity feed. Because that's another thing.
You have to squeeze the bottle, and then it's kind of a process, but
right.
Yeah.
So it would gravity feed, and you don't want to push BCG like through a syringe where it's going to be a sudden push. So you let it gravity feed. Well, then the next step is to take the catheter out and send them home. But if they were getting spasms, just leave that system as is, and it could just flush back. Sometimes if patients were having, more, vigorous spasms, I would use a larger catheter, and instead of the tubing, I would put an open system, which would be just an irrigation syringe taped to an IV pole. And because that's got such volume, if they had a bladder spasm, quite a bit could just go up into that syringe and then come back down. Now that I didn't have to do very often, but I had one patient who really, they wanted to get the treatments, and that was the only way I could do it.
Great idea.
Yeah.
Mm-hmm.
We're smart when we have to be. So I do have a comment from Paula Wagner. I might give oral antibiotics if there's immune issues. That makes sense. And then Susie Swain said, we do antibiotics prior to prostate biopsy and stent removals. So there's hope. People are obviously biopsies. There's no question about it. But I think that the routine use of antibiotics after everything is hopefully dying off. There was a recent article that if you read the UroConnect from SUNA, and somebody had posted about UAs, should we be doing urinalysis because of the concern about treating them for infections? Do we do routine UAs in the office? And I had commented back that it's such a great screening tool. I think that it should be done. Number one, it's not just checking for infections. And we know that the antibiotic guidelines say you shouldn't treat asymptomatic bacteriuria. So that takes care of that problem. But that her concern was, are we over treating infections? But the second thing is you're also screening for diabetes. I picked up a lot of patients who didn't know they had diabetes. And what do they come in with? Urinary frequency. So is it BPH? Is it, overactive bladder? Is it an infection? Or is it just too much sugar in their system? The other things that you're screening for are, pH abnormalities, such as kidney stones, where they could be more prone for uric acid stones if they're pHs. And blood, microscopic hematuria, before they even know they have a bladder tumor. That might be the first key that there's something going on. So I put something through on the UroConnect that I thought routine urinalysis should be performed in the office. I don't know if anybody has any other feelings on that. I'll open up to the panelists.
Yeah, there was a time that we wouldn't do urine dips on a lot of things, and one of them was scrotal pain. We do now because, we know that, if there's blood in the urine, maybe they have a stone that's causing their scrotal pain. Maybe they have epididymitis. We don't, so we do a fair amount of urines on almost everybody that walks in the door, especially all new patients. It doesn't matter what they're there for. They're here to see urology. On men over a certain age, over the age of 50, we will give them the IPSS or the AUA symptom score sheet. We'll do a PVR because even if they're coming in for a kidney stone, you're still urology and you still want to give, just do a baseline. You don't know how many people we actually catch that they think they're urinating okay, and they have 400 cc's as a residual. It's just those one-offs that you can catch, and that it really helps.
Yeah. I do a UA for every new patient. After that, I like to get it at least annually. I don't get it at every appointment, but I agree with Vic. I caught a lot of things, even liver issues with the elevated urobilinogen, diabetes, all kinds of things. So I do think it's a useful tool in the clinic.
I did have a lot of these new MAs who come in, or new nurses, they freak out when they see, oh my gosh, he's got greater than 1,000 glucose, whatever. And I go, are they on metformin? Because a lot of people don't know when patients are metformin, that urine's going to show an abnormally high glucose level.
Yeah.
That's how they get rid of the glucose, through their
Also,
pee.
the SGLT2 inhibitors, those will cause the body to spill sugar in the urine. That's how they work. An easy way to remember is they end in flosin. So I think of urine, flosin, you're going to have a lot of sugar, and that's expected. But they can cause increased risk of urinary tract infections, can also cause irritative voiding symptoms because of all that sugar. But I understand they're quite effective in treating diabetes. So,
Yeah. And Paula Wagner sent in some comments here that I think are valid. The urine needs to be sent to micro, or you need to look under the microscope. That's what I said, but I know it's not being done. I've heard a lot of offices that say they just do the dipstick test, which I still think is a great screening. The office dip is not accurate unless you do CIC to collect. I might take some argument with that. I think definitely on a female, I wouldn't trust it, but I think a male, we always do a double voided sample. We're looking at the second sample, not the first sample, unless we're trying to screening for some type of urethritis or something. So some questions there. And
we will, if somebody comes in and they, it's usually in women, they pee and their urine looks abnormal, a little more abnormal than just a trace, or they may not have nitrites, but they may have large lukes, but they're not having any symptoms. We will, because we always obviously straight cap them, we get, the residual or what have you, and we will recheck it before we actually give the treatment with the straight cap urine, just to see if it's a better specimen.
Yeah, I think it's a good way to, nobody wants to be catheterized if they don't need it. So if you do a female and it comes out clear, you don't need to absolutely get a sample that's catheterized. And that's what one of our docs would always do. If it came back positive, then he'd say, well, we better get a cath sample just to be sure for accuracy. And then Paul Wagner did say that there is some question as to accuracy of dipsticks. They can have negative or false positives and false negatives. But once again, I think there's a better inexpensive test that you can use as just a basic screening tool than a good old fashioned UA. And I would add to it a UA on a male patient, a UA and post-void residual. All right. I don't see any other questions coming in. Any other last comments from the panelists? Otherwise, you guys have been great. I'm glad everybody kind of stuck with some of our technical problems that we have when we have to work remotely, when I have to work remotely. I miss all my fun tools that I make life easier. Paul Wagner did just send something in, and if should clean with betadine, which when you look at the studies, must dry, etc. So I guess the betadine having some issues with the UA stick. I'm not sure, Paul. Maybe you could clarify what you were asking there. But anyway, great show, great presentation, Laurie. Always fun to have you on as a presenter. You have a great knack for it.
Well, thanks.
So we're looking forward to future talks. And Andrea, of course, you're always giving great talks. And I think people get sick and tired of listening to me all the time. So it's nice to have that variety. And I'm just going to take one quick look here. So the betadine she was referring to was for cleaning prior to collection. Yeah, so it can actually, does anybody use betadine for prior to collecting urine? we use BZK just because you don't have to worry about the staining from the betadine for patients. So I
We'll
don't
use
know.
that too. Yeah. Or if they have an iodine allergy, of course, we'll switch over to that.
Yeah, and with the iodine allergies. Well, with that, I'm going to call it a day. We're at that 10 o'clock hour. It's been a great session. Next week, we'll watch your email to see what's coming up. I've had a change in speaker plan from what was on the original calendar. So I'm still working on my final speaker for next week. So you'll see something coming through on the email on that. Otherwise, everybody have a great day. Here in Florida, it's sort of sunny. So I think we're going to, not quite cool weather, cool down a little bit. That cool spell that's sitting up north is working its way down to Florida. Although, of course, when we leave, I hear it's going to be 80 again. So it figures. But anybody who wants to hang out, I will open up the after hours talk, the after hour party. So if you can continue on if you want. Otherwise, everybody have a great day. Those of you up north, have fun shoveling your snow and stay warm. All right. Goodbye. Bye, Andrea.
Bye, Andrea.